Hello, I'm Dr. Asif, one of the surgical candidates. Today I'm going to discuss about a short case. Uh, Here you have already seen some of my short cases. So I hope it will be helpful for you for your final exam. Let's start. So our short case discussions like a cystic swelling, which is called the cystic hygroma, which is one of the congenital anomalies. Later on, it is size should be increased and and containing of clear fluid. So firstly, you must have a rapport with your patient by a good greetings, that is assalamu alaikum, I'm Dr. Asif, MCPS and FCPS file and examining. I will discuss with you about your disease and I will examine you and you will not get hurt. Sir, I need a screening and attendant. Okay, so ensure sanitization by portable sanitization device, and some questions should be asked before starting the examinations. That is, what is your problem? How many days you are suffering from? Is there any pain? And do you have any other problem like fever, like cough? So here you can see there is a swelling in the nape of the neck. So which is brilliantly transilluminant and multiloculation may be present, and in case of children there is a huge cystic swelling in the nape of the neck, and so in case of adult and children both have the same kind of problem, but some cases like initially it is smaller, and but after a period of time period like 10 to 20 years 30 years it becomes enlarged like this. Okay, so firstly, before starting the examination is need to be checked by inspections and palpation. So in the inspection side, the whole of the left side of the neck, the lower part of the left posterior triangle of the neck. So specifically here, the size should be 5 into 6 centimeter, shape globular or maybe circular or irregular. Overlying skin is normal and visible cough impulse present. In case of children, the swelling increases in size on crying. Okay, so in palpation, temperature should be normal, tenderness not tender, shape surface is smooth or lobulated, margin is ill defined, consistency cystic, fluctuation test positive, brilliantly transilluminate, and the partly compressible, not pulsatile. Okay, so overlying skin is free and fixed in underlying structures and passes deep to the sternocleidomastoid muscle. Check the cervical lymph node, which is not palpable because it is not inflammatory swelling or any malignant swelling. That's why lymph node is not palpable. And to check other sites where cystic hygroma may appear, like axillogroin, mediastinum, tongue, and a buccal mucosa. So these are the areas where cystic hygroma may present additionally, or like synchronous lesion. And then such other congenital anomalies like head to toe, like cleft, as it is a congenital anomaly, so there is other congenital anomaly may be present in the body. So you have to check out the other places where the congenital anomaly may appear along with the cystic hygroma, like cleft lip, cleft palate, and the spinal deformity like spina bifida, meningocele anomalies of the anal canal like imperforate anus, cleft foot, umbilical hernia or congenital annular pancreas or biliary atresia, and also some cardiac murmur or any perforation or gap in the membranous or muscular layer like ASD or VSD. Now the presentations, so you have to make your presentation in 2 to 3 minutes. Like there is a swelling occupying the whole of the left side of the neck in the lower part of the left posterior triangle of the neck, which is globular, circular, and irregular in shape, measuring about 5 into 6 centimeter. Overlying skin is normal and swelling increases in size on crying and cough. Temperature is normal and the swelling is non-tender. Surface is smooth, lobulated, margin is ill-defined, soft, cystic in consistency, fluctuant, brilliantly transilluminant, partly compressible but not pulsatile. Overlying skin is free and fixed to underlying structure and the passes deep to the sternocleidomastoid muscle, there is no cervical lymphadenopathy and no other congenital anomaly. So my diagnosis is cystic hygroma in left side of the neck. Okay. Now there are some other questions you need to answer after the presentation. So you will get almost 3 to 5 minutes for giving question answers, like why do you say it is a cystic hygroma? And the swelling is present since birth, and the swelling increases in size when the child cries, and the swelling is situated in the lower part of the posterior triangle of the neck, and the swelling is soft, consistency, surface is lobulated, ill-defined margin, and the swelling is fluctuant but brilliantly transilluminate and partly compressible, and overlying skin is free and fixed to the underlying structures. So what are the differential diagnoses? So that is branchial cyst, cold abscess in the neck, and sometimes in a collar-stirred abscess, that is in this area you will have a collar-stirred abscess or tubercular ulcer followed by abscess rupture. In the above mentioned cases, transillumination is negative, but in the cystic hygroma, transillumination is brilliantly positive, and the solitary lymph cyst, this is a single cyst containing lymph and develops in the same process as cystic hygroma. Thorough congenital, it usually appears in the adult life and is commonly found in the supraclavicular region. Yeah, I have encountered 2 to 3 patients in the government hospital during training. I saw some lymphatic cyst just above the clavicle. It has sometimes appeared. So excision of the lymph node and followed by histopathology is their treatment in that case. So what is cystic hygroma? Is a theoretical questions. Like cystic hygroma is a collection of lymphatic sac containing clear odorless lymph, or this is congenital multiloculated lymphatic sac. It is a congenital malformation affecting the lymphatic channels and arising from the congenital lymph node. And what are the usual sites of the cystic hygroma? That is root of the neck in the posterior triangle, axilla, groin of the inguinal region, mediastinum, and which may involve the parotid or submandibular tongue and floor of the mouth sometimes, because it can be extended through hair to hair, because the cystic hygroma, the origin of the cystic hygroma just lies deep to the sternocleidomastoid, because it sometimes extended to the floor of the mouth, okay, like this. So parotid or submandibular tongue and floor of the mouth can be involved. So what are the atypical presentation of cystic hygroma? So during birth, the big cystic hygroma may causes obstructed labor. Due to the recurrent infection, it may present pyogenic abscess. Cystic hygroma is a mediastinum, may present as a growth in the mediastinum with mediastinal symptoms characterized by dyspnea, dysphagia. Clinically, it is very difficult to differentiate mediastinal cystic hygroma from mediastinal tumor. So in order to differentiate, you must perform CT scan of the chest to identify either it is extended from neck or it is originated in the mediastinum as a mediastinal tumor. So what are the peculiarities? It is multilocated cyst containing clear lymph. Each locule is lined with a very thin wall, so it becomes brilliantly translucent, and there is intercommunication between loculi, so it is partially compressible. Cystic hygroma infiltrates deep to the muscle layer, so it is not some circumscribed swelling due to very thin wall and infiltration into deeper plane, and excision is difficult. Is the treatment plan? What is the treatment plan? If I say what is the treatment, so operative and conservative. So complete excision of the cyst treatment of choice, first things, and if it is not resected due to the extension or involvement of the vital structure like a nerve and blood vessel, in that case conservative. Aspiration followed by injection of the sclerosing agent like hot water, hypertonic saline, and what is the advantages of that? Size diminishes, cyst become more localized, and the dissection is easier because the cyst wall become thick, and repeated aspiration when it is big enough to cause pressure symptoms. So repeated aspiration causes decompression of the cyst. So there are some fallacy of that conservative measures. So there are multiple cysts which intercommunication between them, so therefore single aspiration cannot bring the apparent cure rate, and repeated aspiration leads to infection. It's one of the important problem. So what precautions will you take during complete excision of the sac? And the precautions during excision: the cyst wall should never be held with tissue forceps. You must not, because the wall is very thin, delicate, and it will give away. So chances of rupture is imminent, and also there is a chance of incomplete removal. So there is a finger-like projection from the cyst wall invading the surrounding structures. So every care should be taken for complete excision. So what are the dangers of a complete removal? There are some dangers like fluid and electrolyte loss leading to dehydrations may rarely develop, which is very difficult to correct in a child, and wound infection and recurrence these are the dangers. So thank you very much. That is all about cystic hygroma. You must know this is a short case. So as I have mentioned some questions, so you may not encounter all the questions, but 2 to 3 questions only, so that you can complete your examination within 15 minutes or 10 to 15 minutes, because you have to complete your 3 examination within 30 minutes. Okay, so if you make a division of 30 minutes, so 10 minutes is usually imminent. So you have to complete your shortcuts in 10 minutes. So be careful about time management, because as far as you know all the questions, but due to time you cannot present in front of teachers. That's why your score may be minimum. So that's why you must be very fast and very clear, and must not waste a lot of time during short case. Okay, thank you very much. I like you to subscribe my channel and like my channels and like my videos, so it will give me much more encouragement. So in the next I can have a lot more a choice to make such kind of video in the future. Thank you very much. Peace.